Hi everyone, so my name is Lisa Sheridan. I'm here to talk to you this afternoon about language-led symptoms, language-led syndromes, and what we classically know as the primary progressive aphasias. I'm a clinical specialist speech and language therapist, as Antoinette said, working here in Tallaght. So what we'll look at this afternoon is, I'll describe what are the language-led syndromes, a little bit of overlap with Antoinette, but I'll describe them in a little bit more detail. Talk about how we identify, how we diagnose these patients coming through our clinic, and again talk about kind of the challenges that we see in these atypical cohorts. Then I'll talk about what I know best, the SLT assessment and our management, most importantly, so what we do to try and help some of these patients that we see. So when we think of language-led syndromes, or language-led dementias, or primary progressive aphasias, they're a group of neurodegenerative conditions that share a propensity to target language networks of the human brain, which we all have come to know. Symptom onset often occurs before the age of 65, but as we've seen, we often do, tend to see these people in our clinics that have even, been going around the houses a little bit, and so we can see people over 65, so don't let that put you off when someone's in front of you in clinic. So, thinking about the evolution of the language-led syndromes, so, we've been describing these kind of progressive language symptoms for over a decade, or for over a century, but, in more recent kind of history, we think of Meslin in 1982, who described a kind of a smaller case series of people that were presenting with this progressive language condition and kind of characterised it as fluent or non-fluent. Then we move on to 2011, which is still the international consensus criteria that we use today. So this Gorno-Tempini group based on Meslin's criteria, and that discusses the three subtypes that we've just heard from Antoinette that I'll talk about in a little bit more detail. And then when we think since 2011, even though that's the criteria we all still use and it's the international diagnostic criteria, we do have a lot more knowledge about these conditions, and we've learned an awful lot about phenotyping, pathology, and it's helped us to kind of categorise these patients a little bit more. So there's a lot of great work being done in Queen's Square, and led by the team there in UCL, and they've done a lot of more recent research around more atypical PPAs and the phenotyping, and have come up more recently, they've proposed a staging criteria for PPA. So if anyone's very interested, there's a lot of really exciting research coming out of there. So even though we are learning a lot more, we have a lot more research, we have a lot more knowledge on these syndromes, why do we still consider them quite challenging, quite complex? We think of, over the years, and, as I've learned in all my years here in the memory clinic, that, we once would have thought of PPA, that's the diagnosis, end of, we've tied that up in a bow, and, we didn't really think past that. We kind of, especially as speech and language therapists, thought, okay, we did really well to get this far, we know, it is a PPA, we know it's a language-led syndrome, and that's kind of where it ended for many, many years. But we know now that this is just the clinical presentation, this is the clinical diagnosis. It's extremely important to get it right. We know we want accurate, timely diagnosis, but there's a lot more that comes after that also, as we've heard throughout the day. Each of those different subtypes will lead a person on a very, very different trajectory, whichever subtype they present with. As we've heard throughout the day, we've considered them rare throughout the years. They were, when I went through college, we were kind of given very minimal slides in a 3-hour lecture on dementia, told we would never ever see this condition. And, that's as a speech and language therapist. Obviously things have changed, and we know it's not as rare as we once thought, but they still are more rare than other conditions, still quite complex, and still really, really challenging at times to identify, diagnose, and manage. So when we think of a language-led syndrome, these are three things we really want to get right when we're talking about diagnosis. So a really accurate clinical presentation, a site of atrophy, and if we have it available, pathology. So in the absence of pathology and in certain clinics, we can all look at the person we have in front of us and try and get the best clinical profile that we can get at the time from that person. So I'll talk in a little bit more detail about that clinical presentation and what we might see in clinic. But first we'll think about the challenges again. So similar challenges that have been discussed already across the different young onset and atypical presentations. Particularly for this group, so it is quite a complex assessment, and it does require really accurate clinical syndrome diagnosis, as we know. The subtypes are more rare. People don't tend to see them in their clinics as much if they're not in the kind of bigger services, but you probably will come across them in all of your services at one point or another. The assessment requires access to quite skilled MDT, which is not always available, as we know, and advanced diagnostic tools, which are not always available. And I'll talk a little bit more about the assessment later on, but it's a really important group where the assessment is not just looking at the numbers and seeing where people fall across profiles. It is about really looking at their error types and digging a little bit deeper into the assessment, which often means you require someone who has seen it quite a lot. About a third don't fit into the major categories that I'll talk about. So we hear mixed PPA, atypical PPA really more commonly. And so, I think we've come to know that maybe don't let that put you off what you see in front of you, that if they're not fitting into that box of one of the three subtypes, you're just trying to assess as much as you can and seeing where you think they lie. But it's very common for someone to be mixed or an atypical PPA. Needing to clarify the onset of symptoms. So this is really important for this group again. So, sometimes you'll see someone in front of you that, has had symptoms for a much longer time, and that's why they're looking more like a mixed picture at the minute, because with all the groups, other language domains will become impaired as time goes on. And again, not to put that aside, if someone presents with more of a global presentation, that it could be just a mixed picture. It doesn't necessarily mean that they have been progressing over a longer period of time. As we've discussed throughout the day about these presentations, they're not memory related most of the time. So when people come through their clinics, I have a lot of people that come in and, particularly people that are quite fluent, and it might be very subtle changes, still working, still have, young families or whatever it might be, and they might be reporting tip of the tongue sensation, words not coming out the way they did before, mixing up their words. And sometimes family, friends kind of laugh it off and say, oh, you were always like that, or, oh, but your memory is great, and they might be brushed aside a lot of the time. There's limited standardised assessments for this group particularly. So in speech and language therapy, we use a lot of the, standard stroke or aphasia assessments. There are some standardised assessments for this group. One that we all know, the Sydney Language Battery, but it's more, you kind of have to do a lot of work before you move on to those assessments. So we do tend to stick to the more traditional aphasia or stroke assessments. The leading features, as I said, can be very subtle, and the classification system that we'll talk about sometimes almost describes a more advanced profile, and what you're seeing is very subtle. And people know themselves really well, and they know that their speech or their language skills are not what they were before, but they mightn't necessarily meet criteria yet when they come to see you. So again, language and communication functions are not really comprehensively captured by standard clinical rating scales that are developed for more typical dementias. As we've heard throughout the course of today, and particularly from the patient voice through the videos, people might have attended lots of different services, not been listened to, or given an alternative diagnosis, and so can often be quite frustrated by the time they get to ourselves. Some reports from people, particularly with the logopenic variant, are reported by other groups too. So that tip of the tongue sensation, the difficulty following a long conversation or getting lost with longer sentences. These can be described by a lot of people coming through memory clinics. So sometimes it can be an inaccurate diagnosis, can be missed or delayed. Sometimes considered more of a functional presentation if they're not meeting certain criteria on testing. So again, reinforcing that real need to listen to exactly what the patient is saying. As we know, for this group, younger onset or atypical dementias, we can often see that they're still in employment, might have young children, as we've said, might be financially supporting the family, and we know it's associated with increased care stress and relationship difficulties. So I'll move on to the identification and diagnostic criteria for the language-led syndromes. So you're using the 2011 criteria that's based on the MESM criteria, and this initial table shows the inclusion and exclusion criteria for a diagnosis of a primary progressive aphasia. So inclusion criteria 1 to 3 must all be answered positively. So the person must present with the most prominent clinical feature, must be difficult with language. The deficits are the principal cause of their impaired daily living activities, and aphasia should be the most prominent deficit at symptom onset and for the initial phases of the disease. And then the exclusion criteria for PPA diagnosis. So the patterns of deficits are best accounted for another non-degenerative nervous system or medical disorder. A cognitive disturbance is better accounted for by a psychiatric diagnosis, or if there's very prominent initial episodic memory, visual memory, or visual perceptual impairments, or if there's a prominent initial behavioural disturbance. Then we move on to the classification of the three major subtypes. I'll talk about them more in detail as we go along through each one, but the three that we use most commonly are non-fluent, semantic, and logopenic variant. The criteria sets out quite clearly the core features that need to be present. So for non-fluent, you need to have at least one of the core features, and for semantic or logopenic, you need to have both of the core features, and I'll go through them as we go along. And then in other features, you need to have at least 2 or 3 of some of the other features below. Then they also give you the imaging supported diagnostic criteria, and also you can have a clinical presentation plus definite pathology criteria as well. So the 3 major PPA variants, so non-fluent or agrammatic variant, which is an insidious impairment of speech, sound and connected speech production, and subsequently a lot of other language impairments. The semantic variant, so erosion of knowledge about words and ultimately objects and concepts around all sensory modalities. And the logopenic variant, so progressive anomia and phonological processing, in particular auditory verbal working memory. There's also a few atypical, less common variants that you can see here. I'm not going to talk about them today, but just, if someone isn't fitting into that box of one of the 3, there are lots of other presentations that we do see less commonly. So, trusting in your own clinical profile and clinical assessment. So we'll talk about the 3 subtypes now. So starting off with the semantic variant. So our semantic variant primary progressive aphasia is characterised by impairment of knowledge about objects, concepts. The person tends to lose loss of meaning to objects and people. The person, you might see in front of you in clinic is very, very fluent. They'll have really, really well structured language. They often are kind of have really good masking skills in conversation at times early on, and as you dig a little bit deeper into the conversation and throughout your assessment, you see that maybe there's a little bit more empty speech. It might be lacking more content, because what happens is the person presents with severe anomia, erosion of their word storage and vocabulary, and comprehension of words and objects is hugely, hugely affected. You also start to see difficulties with reading and writing, so surface dyslexia and dysgraphia. In clinic, some of our key assessment tasks are object recognition, single word comprehension and naming, and reading aloud. So some of the clinical pearls for a semantic variant, which I think, the first one I think is really the one that I have always seen with somebody that is presented with a semantic variant in front of me, that perplexed expression at words and conversation that would have really previously been very, very familiar to them. And I think it catches you off guard, and you definitely remember it if you see it in front of you. I had a lady who was in her 50s working in a tax office, chatting. I was thinking, I don't even know why she's referred to me. She's doing so well. And then I said, we'll move over to the computer to do this next task. And she just looked and said, what's a computer? And that completely perplexed expression. And from there, I could see where to assess further. But you kind of, once you see it, it always sticks with you. That kind of perplexed expression, it's something that would really, really have been very well familiar to the person. They often will scaffold with conversation of numbers or geographical references, and verbal knowledge sometimes appears in more specialised lexicons that previously were mastered. So someone had, a really, really, really strong interest in gardening, knew lots and lots of advanced vocab in that area. Sometimes that's where we start to see the deficits originally, so words that would have been really, really well known to them before. So with this variant of pathology, usually TDP43 and some tauopathies. Other things to look out for: prosopagnosia, visual agnosia and other agnosias, disinhibition, lack of empathy, or some obsessions as well. So looking at the diagnostic criteria, for our semantic variant, you need to have the core features of both impaired confrontational naming and impaired single word comprehension. These kind of tasks can be done very easily in a clinic room. So impaired naming, impaired single word comprehension. So the person needs to present with both of those clinical features and at least 3 of the following. So impaired object knowledge, it's a really good one to try in clinic. So any objects around the room or objects that you can grab anywhere and asking them to point out which one you're talking about, or asking them to name some of the objects in front of them. If it's more subtle and earlier on, it can be more low frequency or low familiarity items. Surface dyslexia or dysgraphia, as I've talked about, spared repetition and spared motor speech production. So in the semantic variant, you're looking for that impaired confrontation naming, impaired single word comprehension, and at least 3 of the below. So things like repetition, you'll see someone with semantic variant is really quite fluent. They can do the repetition tasks, no problem at all, and they won't have any of those motor speech, apraxic errors that we might see in other variants. Then we move on to the non-fluent variant. So the clinical characteristics of a non-fluent variant: often slow, effortful, hesitant, distorted speech sound errors, can be quite telegraphic, errors in grammar affecting their syntax. You'll often see this kind of groping of the target word or speech apraxia, the person really trying to get the word out, looks uncomfortable for them, can make the other person uncomfortable at times, they really look like they're struggling. It's impaired motor programming of the speech and reduced articulatory agility. There can be impaired comprehension of more complex sentences and information. So, we kind of sometimes think that there's no comprehension difficulties at all with a non-fluent variant, and early on there usually are very minimal. But we can see that impaired comprehension of more complex sentences and information. Written communication is usually a strength at the beginning, and some people do rely on that as a form of communication due to their frustrations. Good to know early on from your assessment if something like written communication is a strength, because it's really good to know for future management and therapy, and to keep the person independent with their communication. The non-fluent variant often is the most obvious. If someone is presenting with these, it's an obvious speech issue. It can be very subtle. Someone can come along very early on. They might be quite minimal in general conversation, or it can be a little bit more obvious. So you can see those slow speech, groping, apraxic errors, and the syntax or the grammar might be a bit off. So key assessment tasks. Picture a description to get a really good speech sample from this group, and repetition of polysyllabic words. So you're trying to really look at that motor programming and how those polysyllabic words are presented. So some clinical pearls for this group. So we often have seen a re-emergence of what they would call a childhood stammer. So a bit of digging around that in your case history. Binary reversals early on, so yes, no, he, she. They can usually self-correct early on, but kind of probing a bit more if you haven't seen it in your conversation. Deficits of central auditory processing sometimes, so environmental sounds, emotions, unfamiliar accents. And naming and single word comprehension deficits can develop over time. So, and we see that across the board. We do see other language domains, can be impaired in different areas. So we're trying to think of the core target group for these subtypes. Pathology, most often tauopathy, but it can be the FTD syndrome also. And other things to look out for: someone being very dysexecutive, and orofacial and limb apraxia. So, looking at the diagnostic criteria for non-fluent variant. So the core features here: agrammatism in language production, or effortful halting speech with inconsistent speech errors and distortions. So a noticeable kind of grammar difficulty in language production in their sentences, kind of telegraphic speech, or effortful halting speech with obvious speech sound errors and quite apraxic speech. And then at least 2 of the following: so impaired comprehension of syntactically complex sentences, spared single word comprehension, and spared object knowledge. So in contrast to the semantic variant, that's spared single word comprehension and spared object knowledge. Then we think about the logopenic variant. So characteristics are word finding difficulties, often manifested as these pauses, these kind of big pauses in their spontaneous speech. A lot of tip of the tongue hesitations early on. A lot of people that sit in front of me, even with very subtle difficulties will say, I'm kind of scripting in my head because I know I'll go and talk to someone and I won't be able to get that word out, and it's tip of my tongue, and they can be very early on. Phonological paraphasias and confrontational naming, speech sound errors, spelling errors, and it can sometimes be challenging to distinguish from typical Alzheimer's disease. It doesn't have that clear deficit like the other forms. We have a really good profile for logopenic, but for non-fluent, it's very obvious speech deficits, and for the somatic variant, it's that very obvious loss of meaning and loss of word knowledge. Key assessment tasks for the logopenic variant are repetition of phrases and sentences, a really good connected speech sample, naming, and reading aloud. All things that can be done very, very easily in clinic rooms. So some clinical pearls for this variant. So sentence repetition is a really, really excellent clinical task for this group. The person might continue, try and repeat the sentence over and over again. It can be long phrases or sentences. They really try, and they might add in a word. There might be some substitutions, some approximations, but it just ends up becoming much shorter and inaccurate. And you can almost see that perplexed face again of like, I really thought I had that, I really thought I could recall that sentence. Sometimes like jargon and neologisms, so like kind of almost words that are made up, may appear in conversation or in assessment tasks. And the pathology is usually AD pathology. Other things we might see: reduced digit span, limb apraxia, visuospatial agnosia. Again, going back to our diagnostic criteria, so for logopenic variant, the core features both impaired single word retrieval in spontaneous speech and naming, and impaired repetition of sentences and phrases. So you can see that sentence repetition is actually one of the core criteria for diagnosing a clinical presentation of logopenic variant. And then at least 3 of the following, so kind of speech errors in spontaneous speech and naming, spared single word comprehension and object knowledge, spared motor speech, and absence of kind of frank agrammatism. So they're the core criteria that we use to diagnose those 3 subtypes, and it's really helpful when you have any of your assessment to hand to look through those and kind of be able to tease it out between the 3. So moving on to my SLT assessment and what I might do to tease those subtests out. So when we think of communication, we're thinking cognition, language, and speech. So a lot of the time in primary progressive aphasias, and they're called language-led syndromes, it just talks about language, but we mean speech as well, and including our cognition also. So beginning off, a really detailed case history and interview. So you're asking about, is that an insidious onset, was it progressive? And teasing out, do the symptoms appear largely language-led? So you want to figure out if that speech and language dysfunction was the initial and most salient clinical complaint, and is that kind of what's impacting their day-to-day? People often don't notice this. They know something is wrong. Other people don't really, they mightn't necessarily know there's something going on if it's not all about memory. So they might be just thinking, oh yeah, like I've noticed you're not getting the word the odd time. And sometimes there's a lot of teasing out to do at the start. Things to have addressed and looked at: previous verbal skill, previous education, occupation, current or previous, bilingualism, really important, and any developmental difficulties that a person might have presented with. And also making sure a really up-to-date hearing and vision check, which can really impact on someone's communication. Once that language-led presentation is suspected, then we further assess and see the need to further subtype then. So these are the kind of things that I will look at in my assessment. So as I said, case history, getting a really good picture description, I've done with somebody, so a really good sample of their speech. That can give so much information. We pull out the cookie theft or whatever you might have around. It gives us an idea if anyone is presenting with that telegraphic speech. They might be giving very short, simple sentences. You'll be able to see if someone's presenting with the more logopenic type presentation of those spontaneous pauses in their speech. You'll also be able to look out for any kind of Parkinsonism creeping in. Is someone that's slightly hypophonic, dysphonic? And it gives us so much detail in that picture description. So that one task can give us a lot of information. Naming, looking at words and objects, and high and low frequency. So sometimes people, for many different reasons and different educational levels, bilingualism, whatever it might be, the lower frequency might be just difficult for them at baseline, so you need to tease that out a little bit more. Verbal fluency, so category and letter. Repetition, so word up to complex sentence level. Comprehension, looking at single word to paragraph level. And, you know, this one is important. Like, if we think of someone and think, oh, their comprehension, you know, I think seems okay from their general conversation, but if we think back to our semantic variant, it's that single word comprehension that actually might get them, you know, so it's picking an object of 4 or a picture of 4. So really good to test across the board. Narrative discourse, are they able to tell you a little bit about, you know, their day, the holiday last week or whatever it might be. Semantic knowledge, so being able to tell about, you know, word knowledge, word meanings. Reading and writing, really important to test. Detailed motor speech assessment and dysphagia assessment. So, you know, I will, particularly if I'm querying semantic or non-fluent very early on, we'll talk about swallow. I'll ask everybody, but very much might move on to an early swallow assessment in that group. And then some kind of quality of life measure. These are the assessments that I would use on the side. So some of them might be familiar to people, Boston naming test. Other tests are just more common to speech and language therapy that are used across stroke. So Western aphasia battery, comprehensive aphasia test. And these tests usually have all of these subtests in it. So I'll just pick and grab from each of them. The Sydney Language Battery is a really good assessment for subtyping PPA and is available online on the Sydney University website if anyone needs it. What I said earlier about the assessment, so it's really good to look at error types, and for the language-led syndromes, you really need somebody who knows what they're looking for with these assessments. So if we think of something like repetition, it's not enough to give a score about repetition. So the repetition difficulties for somebody with a non-fluent aphasia will be very different to the repetition deficits in the logopenic variant. So you need to tease that out. Was the sentence breaking down because of a more logopenic profile, or was it because there was multisyllabic words throughout that long sentence that made the speech apraxia more obvious? Similar with naming. If there is a naming deficit, is it like a severe naming deficit where the person has no semantic knowledge about the word, they're like, I've never seen that before in my life, or is it, which is a more semantic variant, or is it more logopenic where they're saying, I know what it is, I've seen that before, oh, I visited Egypt, I've seen that before, and it's that tip of the tongue phenomenon. So it really is important to know what you're looking for in a lot of these assessments. When we have our clinical presentation, that's just one piece of the puzzle. So coming back, it's usually our MDT where we discuss all the next steps. So if myself or whoever it might be brings that clinical profile or subtype to the rest of the team, there's a million other things that happen after that. But some of the core things that are important for this group, we will definitely have an MRI brain if most people might be sent for CSF testing usually, and might already have it done. And then for my other MDT colleagues, really great to look to either the nursing, OT, neuropsychology colleagues who've done neuropsychological testing, be able to get a really good baseline ability of a person and see where language fits throughout that profile. Really good functional assessment from our OT colleagues to see where they're at in terms of function. And we always rule out any other causes in our team meeting. So again, as I said, that kind of clinical profile is just one part of that whole puzzle as we know now. Why is all of this important? Why do we need this accurate diagnosis? As we all know, early specialist assessment leads to a really accurate diagnosis and really early intervention, which is what we all care about. So particularly for this group, accessible information provision, it's something they wouldn't have heard of all the time. They may never have heard of the words at all before. Being able to provide a good, detailed, if written or verbal information about what it is they are presenting with themselves. And also for this group, when you think of progressive speech and language and communication deficits, being able to facilitate decision making and care and future planning really early on when someone is able to make those decisions about themselves. Just to touch on the impact of PPA or language-led syndromes, there's a speech therapist in the UK who did an article in 2019, and we know now that there's increased social isolation and reduced confidence. A third of people with PPA or language-led syndrome will experience depression. Spouses report loss of relationship and meaningful social interaction, and the dependency on a spouse for communication is huge. So just to finish up on my management, so with each patient it's symptom-led always, so as we've touched on, those presentations will all lead to a different profile for each person, very different for someone presenting with a logopenic AD versus someone with an FTD or a PSP. So it's symptom-led. Myself and my colleague will hold on to a patient throughout their journey, link them in with local services and be there for those kind of in-between parts, whatever it might be. So, you know, if it's somebody, a lot of my job during the week is spent linking with SLTs around the country, of discussing maybe if they haven't seen the person before, seen this kind of presentation before, what they can do, and, you know, talking it through. And we also can bring someone back for more like advanced testing, like for swallowing impairments, videofluoroscopy, fees, whatever it might be. So it is a phased approach also in language-led syndrome. So initially, usually there's not a huge cognitive impairment early on, and we try and get in there with that impairment-based therapy, not to try and improve things like we do in the stroke group, but to try and maintain where the person is at and give them the strategies that can be used when they're well, when they're able to engage. And then moving on from that, we follow them along their journey and do direct or indirect. So indirect therapy would involve the family, the carers, groups, whatever it might be. For this younger group, supporting by technology is really, really important. And also, you know, in my therapy and any of the MGT's therapy, all the therapy targets are meaningful and personally relevant. So to conclude, can be very complex, difficult assessment and diagnosis. We are really striving for the accurate diagnosis and as timely as possible. And just like we're always here as a team to bounce off, you know, if somebody is querying someone presenting with this presentation, and, you know, specifically around SLT, if anyone needs, you know, some advice around anyone, we're happy to help at any point. Thank you.